Good morning and welcome. Today we are excited to talk about ways to maximize the impact and reach of medications for opioid use disorder in the emergency department. So I think, the main point of all the projects that we're doing to expand access for opioid use disorder treatment is to relieve some disparities that exist currently. So right now, fewer than 20% of patients who have opioid use disorder are receiving evidence-based medications such as buprenorphine or methadone. Unfortunately, within the United States, there are even worse disparities within other groups. There's disparities based on race, military service, incarceration, based on where you live in the country, based on your pregnancy status and your age. Once we go through these different groups in ways that we can try to alleviate some of these disparities, we're going to try to remind everyone that that Michigan Opioid Partnership can continue to offer technical assistance opportunities to our emergency departments. And then we're going to take some questions and have some closing statements about other substances we may be able to treat in the emergency department as well. So I'm Nick Rademacher. I'm an emergency physician in Grand Rapids, and I work with Michigan Opioid Partnership to help other emergency departments implement pathways to treat people with medications for their opioid use disorder. I'm so happy today to be joined by Ariana Campbell and Kara Poland. Ariana is an emergency department PA with more than 20 years of clinical experience. She's an APP for U.S. Acute Care Solutions at Marshall Medical Center in Placerville, California. That's where she initiated an innovative program to treat patients with opioid use disorder back in 2017. She serves as the CAPA's professional practice committee and is developing a curriculum in addiction medicine with AAPA through the NIDA grant. She also serves as director and co-principal investigator for California Bridge program, a program for which she's a co-founder. California Bridge is over 250 hospitals, soon to be 300, and they're working in 36 states to help expand access to medications for opioid use disorder. My other presenter that I'm so happy to be with today is Dr. Kara Poland. She's an associate professor at Michigan State University. She earned her medical degree from Wayne State, and she was trained in internal medicine at St. Joseph Mercy Hospital in Ann Arbor. She had addiction medicine training at Boston Medical Center in Boston, and she received her master's degree in education from Boston University. She's interested in educating healthcare providers and providing in training to improve care for patients with substance use disorders, particularly during pregnancy and early parenting. We're also honored to be joined by Sarah Wendells. Sarah Wendells is a vital component of the California Bridge program. And Sarah, are you done with your MPH or is continuing to work on it through Johns Hopkins?
Continuing. Yeah, I'm also Wonderful. A fellow at Bloomberg American Health Initiative as well at Johns Hopkins. Mm-hmm.
Wonderful. So Sarah won't be presenting today, but always is very important as she drops information into the chat for us. If you have any questions, she's likely to be the one to respond to those specific questions. So thanks everyone for being here. So after today's presentation, I hope that we can all recite some key statistics that highlight the significant racial disparities present in Michigan when it comes to opioid overdose and deaths. We can conceptualize how inequitable MOUD access impacts health disparities and overdose rates. We want to describe how access to treatment can be improved for underserved populations, propose methods to integrate care teams and utilize all specialties, and summarize interventions that can be used in the ED for other substance use disorders based on your feedback from other presentations we've had this summer. So the first disparity I want to talk about is disparities based on race. And so there's kind of three subcomponents to this. Initially, we're going to talk about some general race-based disparities, and then we're going to highlight disparities among Black and Native American patients. This is data from the CDC from this year that showed pre and mid-pandemic overdose rates have really separated based on race, and where initially people, Black Americans, Native American, and white Americans were 27 to 25 per 100,000 overdose deaths, which is way too high. But during the first part of the pandemic, there's been this huge disparity in which now Black Americans are dying at a rate of 39 per 100,000 people, and Native Americans up to 36, while white Americans are still too high, also at 31. When we look at the general state level data, sorry, for some reason it's not progressing when I click on it. So this is, independent of race, but Michigan is in the cohort of states that has some of the highest overdose rates in the country. So we're not really doing well overall, but when we break it down, sorry, I needed to take control of the screen. That's why it didn't work. Got it. When we break it down by overdose death rate by race, we can see that there's this persistent disparity in which Black patients continue to die at a higher rate than other races. You will notice that the data for Native Americans is missing here. And unfortunately, when I tried to go through at like a county level to figure out what was going on, when you have fewer than 7 or 9 deaths in a racial category, the state will often kind of exclude that data because it's too small of a number. So a lot of times it's hard to see the disparity within the Native American community in Michigan. But when you do look at overdose visits to the emergency department, you can see that frequently Native Americans are at elevated risk compared to other races as well. And then you'll also see here that not only are Black patients overdosing and dying at a higher rate, but they're coming to the emergency department to us more frequently. And so we can certainly be a place to provide help. I think, it's important to know that the rate of opioid use between races is extremely similar, like within a statistical variance. So white Americans use opioids at a rate of 4.6% and Black at 4%. So there's really no significant difference that would be the cause for these elevated rates of overdose use or overdose death and ED visits. So it's certainly something else. And I think that based on looking from treatment data from other states, our neighbors in Pennsylvania recently had a study that showed that Black Americans are much less likely to receive medications to treat their opioid use disorder than their white counterparts. And so this is true for naltrexone, methadone, buprenorphine, just all classes. They're just less likely to be treated than white patients are. This was replicated by a paper in 2019 that showed, so buprenorphine was approved in 2002. And so there's a slow rise in buprenorphine prescriptions to 2011. And then it really took off for white patients. But as you can see, it's remained relatively steady for Black patients. And the graph on the right side shows that many of these gains are in clinics that accept only private insurance or self-pay. But when you control for payment type, age, and sex, Black Americans still get less buprenorphine than other races do. So I do think that there's treatment disparity goes a long ways towards explaining some of the outcome disparities that we see. The reason that this is important, and I'm going to take a quick step back and talk about the effectiveness of these medications. The reason it's important is because buprenorphine and methadone are highly effective in both treating opioid use disorder, preventing opioid overdose death, and acute care use. In Baltimore, which is a city with a persistent high rate of opioid use disorder, as treatment increased throughout the early 2000s, we saw the rate of overdose death decrease. This was also replicated in France in the 90s. They had a heroin epidemic in which they had 564 overdoses. Wouldn't that be great? We now have 80,000 in the United States. But when they deregulated buprenorphine access, it just dropped precipitously to 5 years later, there were only 120 deaths. So expanding access and providing buprenorphine to patients is extremely important and effective. Data from 2020 shows that people treated with buprenorphine or methadone have a significantly reduced rate of opioid overdose death and acute care use as well. So it's just seen time and time again that these medications are helpful, but they're just not being provided equitably among different racial groups in the United States. Another graph that shows the adjusted hazard ratio for someone on medications is 0.18. If you're doing abstinence-based treatment, your rate of overdose increases, and if you stop your medications, it increases as well. So being on medications long-term is the key to preventing negative side effects from opioid use. So I think it is also important to step back and look at this from a bit of a historical perspective. And drug use has been stigmatized off and on throughout history. Even alcohol, you had abolition in the 20s, and then it became legal again. But the kind of the modern history of stigma and discrimination really comes in the 60s and 70s with the heroin epidemic at that time. And so it can be traced back in New York State. Nelson Rockefeller was the governor at the time, and he was the first to implement a set of laws which was meant to, seemingly meant to reduce opioid use in the community. They were mandating life sentences for selling hard drugs. They eliminated plea bargaining and suspended sentences. They eliminated treatment as youthful offenders for those 16 to 18. They mandated life sentences for those committing crimes while on drugs, and mandate prison time for possession of an ounce of heroin, cocaine, opium, or morphine. So just these really tough drug laws that I think at face value seem to be race neutral. But as we'll talk about shortly, their implementation was not race neutral. And sometimes when these things seem to be race neutral but aren't, people can speculate about why might there be some discrepancies. But I think it was telling that sometimes the quiet part gets said out loud. And that's so John Ehrlichman was an advisor to President Nixon, and he gave an interview in 2016 in which he said, "We knew we couldn't make it illegal to be either against the war or black." But so these are two groups that were political opponents to Nixon at the time. And so by getting the public to associate hippies with marijuana and blacks with heroin, and then criminalizing both heavily, we could disrupt these communities. We could arrest their leaders, raid their homes, break up their meetings, and vilify them night after night on the evening news. Did we know we were lying about the drugs? Of course we did. And so there's really this effort to negatively portray essentially domestic political opponents at that time, which gets kind of rolled out as this anti-drug policy. This gets compounded in the 80s when you have the crack epidemic, and they set basically laws. The Anti-Drug Abuse Act of 1986 sets crack cocaine penalties to be 100 times higher than that of powder cocaine. I think as is historically known, crack cocaine was used more predominantly in Black communities and powder cocaine in white communities. And so, this again, as something says nothing about race in the text of the law, but it is set to implement these penalties that disproportionately impact Black people in the U.S. compared to other racial groups. And so then what you see historically is that while only 12% of Black Americans, Black Americans make up only 12% of drug users, so they're a minority of those that use drugs, but are almost 40% of those arrested for drug offenses, and are almost 60% of those in state prison for drug offenses. And so this is really just the implementation of these seemingly race neutral acts. And that's for cocaine. And then if you look at heroin, well, significantly more white Americans use heroin. There are a lot more white Americans than Black Americans. There are 3 times as many Black heroin offenders in the federal prison system. And so huge discrepancies in the criminal justice system when it comes to how drug use is treated. It was not treated as a chronic medical condition as we are now teaching to treat it, but it was a criminal offense to be penalized. This is Michigan specific data. And so since we're initially just focusing on Black patients, you can see they're 15% of the state of Michigan, but make up 53% of the prison population. And this is just largely due to drug laws. And so what this, I think, has done, again, when we go to new hospital sites and talk to providers, the most difficult thing that we come up against is stigma. And so by criminalizing drug use, it really set this precedent that drug use is morally wrong. It's something to be punished and not to be treated. And so it's created this system of stigma that's made treatment, and specifically treatment among Black patients, more difficult. There are studies that show that if you review the medical records of Black patients, there will be more negative connotations or negative language in their charts compared to patients of other races. In the media, people typically depict drug users as Black patients and not white or Hispanic. And so there's just this built-in level of discrimination that makes it difficult to get people to want to prescribe and treat this as a medical condition for Black patients. And then on the other side of it, it also makes Black patients more distrustful of us as medical providers and the healthcare system, hospitals, addiction clinics, because it's just so baked in that they're going to be punished for drug use and not treated, that I think that's a large part of the reason that there's this discrepancy in accessing treatment. So we have this unequal access to care. The other arm of this is that there is differentiation in the type and quality of medication treatment that Black patients receive. And so white patients are more likely to receive buprenorphine for the opioid use disorder, while Black patients are more likely to get methadone by a pretty significant margin. Methadone can be great for some patients, but it does mandate, at least initially, these highly structured, often daily clinic visits that can make it difficult to remain employed or take care of your kids. You have to go in every day, often very early, and it's just a barrier. Whereas buprenorphine, initially you'll get an appointment every week or two, and then you can just dose titrate, and it's just more conducive to living a normal life, which is what we want people with opioid use disorder to do while they're taking medications. So in this paper, they kind of lumped Black and Hispanic patients together, but they comprise 40% of those in methadone, despite being a much less aspect of the population. But so while they're on the medication that's more challenging to take daily, which is methadone, they're also more likely to be dosed at a lower dose that's thought to be ineffective. So under 60 milligrams per day is really not therapeutic for many patients, but having a high percentage of Black patients was the strongest predictor of a clinic providing low doses of this medication. And so they're not given medications at an equal rate. And when they are given medication, it's the one that's more challenging. And then when they're given the medication that's more challenging to take, they're given it at a lower dose than that's thought to be therapeutic. So this is associated with discontinuation of therapy and poor outcomes, and I think continues to explain why Black patients receive care at a lower rate and continue to die at a higher rate from their opioid use disorders. These papers propose that these methadone clinics lacked resources and staffing to adequately up-titrate doses for patients and keep them engaged. Some held just philosophies that were having intensive behavioral therapy with low-dose methadone strategies. Unfortunately, these have been found to be less effective than higher doses. And from the patient perspective, I think due to this history of criminalization of opioids, there's a lot of skepticism and hesitancy to be maintained in these clinics, and they may see medications as a form of social control, and they reject higher doses due to these kind of these insults from historical perspectives. The other thing that is mentioned in some of these papers, and I think anecdotally is probably true, is that while Black patients actually use heroin at a lower rate than white patients do, they do use cocaine and crack cocaine at a higher rate. And so what's happening is you have contamination due to the abundance of fentanyl. You have contamination of non-opioids like cocaine. And so if you're having opioid naive patients use what they think is their normal cocaine, they're more likely to overdose and die unintentionally. And so I think that's happening. And then the other thing, when I worked in Baltimore, and Andy King, who works in Detroit, kind of mentions this as well, is there is a group of patients who have been using heroin safely, right, quote unquote safely, for decades. They've had the same drug supplier, they've used the same amount or slightly more, as their tolerance goes up, they use a little bit more, but it's been relatively safe for them. I have patients in their 50s and 60s who've used and really don't overdose. But what happened in the 2010s is the contamination of the drug supply. And so when you have patients who use for a long time, and then you get a new drug introduced, they have kind of suffered these unintentional consequences. So the CDC has offered a variety of solutions to help with these disparities based on race. And for Black patients, they're suggesting we use culturally appropriate practices, and I'll get into that in the next couple of slides, provide support groups. And so I think this is where we implement and we incorporate other care members. And so I think ideally in an emergency department, the care team is going to look and have similar life experiences to our patients. Sometimes, for other reasons that are outside the scope of this presentation, it can be difficult to match your patient population with APPs and physicians. And so what we really need to focus on is trying to get a diverse set of nurses, technicians, peer recovery coaches, case managers, so that someone on the team will have a shared life experience with the patient, and they're more likely to trust the advice given to them from their medical team. That has to do with linking people to care and recovery. If you have a peer recovery coach, if you have a lot of Black patients in your community and you have Black peer recovery coaches, I think that is going to make it more easy to link people to ongoing care. There's the mention of expanded insurance coverage. I mean, that's going to only go so far when these clinics are only accepting private and self-pay. But what we really need to do is have Medicaid increase reimbursement for addiction care so that they're more willing to treat patients with Medicaid only. Stigma reduction, I think, does go hand in hand with this reduced criminalization component, in that data shows that white patients who get into the criminal justice system are much more likely to have their opioid treatment paid for by the state. And so that needs to be equalized as well. And then offering telehealth does make it easier, because we also know that Black patients are less likely to have reliable transportation. They're also less likely to be offered additional adjuncts to their care, like housing support and food support. And so trying to to get everyone in the emergency department in the social services sector to offer equitable services to Black patients can try to increase the rate that we're effectively treating opioid use disorder. So more specific proposed solutions from this paper by James and Jordan suggest that every time we do an intervention, there should be racial impact assessments before it's done to make sure that care is delivered equitably. And SAMHSA has actually done an interesting faith-based community initiative where they use their contacts within Black churches, because it's known that in Black communities, religious institutions commonly anchor culture, social support, and mutual assistance. Of course, there are regional differences with this, so you do have to be careful kind of, painting everyone the same, but it's been shown for people with cocaine use disorder that if you offer services through a faith-based community initiative, they had a 55% higher rate of success than those not in culturally sensitive groups. And so I think this is an interesting lead that may help solve some of our problems. And of course, criminal justice system is a little bit outside of our scope, but we can all advocate to try to increase treatment. And that's certainly something that the Community Foundation for Southeast Michigan is doing, is trying to get treatment initiated in jail so that this is not, people while they're serving their sentence can also get treatment for their opioid use disorder. And then I think it comes back to us, and that one of the big disparities is getting people started on treatment. It can be challenging, but many of our emergency departments are in urban centers with a high percentage of Black patients. And so if we can implement these programs, then I think we can do a lot to alleviate our state-based disparities and directly improve care. So that's all I have for Black patients. I'm going to talk about Native American patients in just a second, but our quick question is that Black patients with opioid use disorder are more likely to, and I have 4 options. The answer was D. Unfortunately, experience kind of barriers throughout the whole process. Next, I want to talk about Native American patients briefly, because they're the group with the second highest rate of overdose deaths. And basically what I said before is they're not included in the death rates because the numbers are relatively small and because their population is small within the state. But if you look at ED visits for overdoses, they're kind of consistently high. You can see a lot of variation because when you have a small number of variation is going to be high, but it's known at least at a national level too that Native Americans have poorer outcomes when it comes to opioid use disorder. And so these papers show that about 50% of patients who are Native Americans are retained in treatment at 6 months, which isn't all that different from kind of the median. But at 1 year, they are slightly lower to be engaged in care than the general population. And part of this is thought to be from the medications, the facilities they have access to are less likely to offer maintenance. So they're more likely to offer medications in a tapering fashion, but the maintenance arm, of course, this isn't good for a general population, only 27% for the general population, but for those who are Native American, it's 22. So this is an area I think quality of care can be improved. And these focus groups, they advise that the way to increase participation and care for Native Americans is to try to integrate Western and Indigenous worldviews and understand that often there is a desire to be free of medications within Native American communities. And so that ways to kind of to get people to continue in a maintenance course is to be involved in the community and have these community-based participatory research approaches and talk to their leaders and see how you can get buy-in from several different levels within the community. Second question is, Native Americans are with opioid use disorder are more likely to okay. So it's receive care at facilities less likely to offer maintenance. I do want to take a second to thank Jason Gibbons. He's a postdoc at Johns Hopkins as well. He did a lot of work in compiling many of the articles I used to develop the last set of slides. Any questions or comments about race-based disparities and what we can do to help with this?
I just wanted to mention, I mean, I know that in this whole series that we've been doing here, we've been talking a lot about outreach to community organizations as a really important component to the work that is going on within the emergency department, within the hospital. And I think that what you have outlined, Nick, really points to the importance of building relationships with other organizations that have a lot more trust within the community, specifically with Black and Native American populations within the community. And I think that's just, you know, just kind of tying it all together, a really important component of this work in how we're able to actually make sure that it is reaching the people that need it most. So thank you for sharing that. I've also put quite a few of the relevant resources that I know of that I think could be helpful for everybody listening to this recording and hoping to make a big difference in this work.
Thank you. With that, I'm going to move on to disparities based on history of military service. So I'm going to present a component of a presentation that was developed by a psychiatrist at the VA system in Ann Arbor. So thank you very much for letting me share your slides. So substance use disorder is more common in those who have a history of military service, but it really does depend, the era in which they served, with younger veterans having a higher rate of substance use. I guess let's go back for 1 second. Carla Scott has a good question about differences in the medications that are offered. Do you have any idea why? So yes, I guess I didn't touch on that. So there are basically the short answer is the number of buprenorphine waivered prescribers in zip codes with a high density of white patients is greater than those with zip codes with a high density of Black patients. And methadone clinics are more common in zip codes with high density of Black patients. And so it's just about like a proximity. And then it's also what type of insurance is accepted. And so you have Black patients more likely to have Medicaid, and that's less likely to be accepted by those providers that do offer buprenorphine. And so I think that's the main underlying problem here, is just access to providers that are willing to provide based on insurance type. Yeah. Okay. So we know that the rate of opioid use and substance use disorders is highest among the younger veterans, and that there has been a pretty significant overdose death increase in the VA population from 2010 to 2016, which is similar as the general population. So I would assume that it'd probably be exponentially increased since 2016 as well, but there has been a pretty similar increase over time. What seems to make effective treatment for veterans extremely difficult is that they often have comorbid conditions. such as psychiatric illness. And so we know that 15% of veterans have a psychiatric illness, and 25% of those have a severe mental illness. And so attending appointments, going to clinic every day for methadone, like these things are all difficult when you have an underlying mental health condition. And then there's a large number that have, both. And, that's really the group that is, most difficult to access, unfortunately. Do note that the most common substance use disorder among veterans is alcohol, but still there's a decent amount of other opioids and illicit drugs as well. So it's not surprising, I think, that PTSD and substance use disorders are common. And so 1 out of every 3 veterans seeking treatment for substance use disorder also has PTSD. And we know that having both can lead to poor outcomes and complicate future treatment. I joke with my residents that when you're allowed to have one, you can either have medical conditions or you can have psychiatric conditions, but you can't have both, because once you have both, it's just hard to treat either of them, quite frankly. And so they not only do they have higher rates of psychiatric disease and substance use disorders, but are also more likely to have medical conditions such as obesity, sleep apnea, and chronic pain, in addition to hepatitis C, HIV, hepatitis, and chronic respiratory disease. So it's just, there's a lot going on that makes it harder to treat those with a history of military service. But, and I think not surprisingly, the negative outcomes for veterans with substance use disorders remains high. So after adjusting for age and gender distribution, veterans are twice as likely to die from opioid-related overdose than the general population. And that's from 2010 to 2016. So we have this huge problem in the general population that's twice as bad among veterans. What makes it even more dangerous is that those with a substance use disorder have a significantly increased risk of suicide attempt, plan, and serious thoughts of suicide. So you have the direct consequence of an opioid overdose, but also these, secondary things that can cause them harm as well. And so those who had died by suicide in 2017, almost 60% had a mental health or substance use disorder in the previous year. Highest rates of suicide were with those with bipolar disorder and then diagnosed with an opioid use disorder. So I think some of the positives I want to highlight here is that the VA actually has a plethora of services that they can offer veterans. And so I left this slide in here because we'll send it out to everyone, but if you have a patient and you want to find a location for treatment, I think these links can be helpful. And know that the VA handbook does, you may wonder, are they going to offer medications? Are they going to offer the whole array of services that we could get out of the VA system? And the truth is that yes, they're advised to offer medications, motivational therapy, cognitive behavioral therapy, 12-step counseling when appropriate. This can be for alcohol use, and then pharmacotherapies as well. So everything is available within the VA. Not only are all different types, but all different kind of locations are available. That, you have inpatient care, residential care, intensive outpatient programs, and then these combined PTSD and SUD services. So if someone has VA healthcare, I would look to the VA first, because this is just a special population that they're probably best suited to care for. Despite that, there are pretty significant treatment gaps. And we know, as I mentioned upon opening, there's a treatment gap among the general population that less than 20% of patients with an opioid use disorder receive treatment with medications. And this is pretty similar for veterans as well. But, no surprise, people that have co-occurring mental illness and substance use disorders, they almost get no treatment. And that's just because how difficult it is to treat both types of conditions. so we know, as I mentioned, that there's unmet treatment need in veterans, but it's pretty similar to the general population. One example is that those with an alcohol use disorder, like only 4% were in treatment for their substance use disorder a year later. So there's certainly room for improvement. What's thought to be challenging, other than the, so I guess the two things are really distance to care, that many veterans live in rural communities. And so I think we're hopeful that with our ED initiatives and trying to get into smaller EDs, that maybe we can be a bridge. And then the dual diagnoses make it challenging as well. I'm just putting this slide in here so that if you ever have a veteran patient, you can use these resources. And I'm hopeful that everyone takes away that substance use disorders are more common in veterans with mental health disorders, and that they're vulnerable populations for substance use disorders, overdoses, and that the VA is the largest provider of substance use disorder treatment in the country and has made strong efforts to increase medication treatment. And so if you have someone eligible, they're probably the first point of contact I would attempt to make. So last polling question that I have is, veterans with an opioid use disorder are more likely to A, B, C, or D? I was going for have co-occurring mental health diagnoses, specifically PTSD. So while the VA does have specialized addiction care, I guess I was saying that it's not necessarily easy to access due to their rural locations and just kind of some systematic barriers at times. I think we have a discussion, and then we can move on to disparities among the incarcerated. Anyone with any questions or discussion points about disparities among veterans? All right. Thank you much for your time and attention. I hope we can all work together to try to close some of these treatment gaps.
All right, thanks, Nick. There's actually, I have to say, I'm going to talk about, disparities based on incarceration, our justice-involved population, and there's a lot of intersection here. So, in fact, I think I have some things I'll cite that are the same. So, thank you for that. And as we go on, I just think it's really important to note that there's these huge disparities based on incarceration, and then when we don't pair any treatment, you can imagine how much worse the issue is, and there's like a lot of compounding there. So so let's talk about this. So first of all, I just want to get a little bit into the history of this, and Nick, I know you touched on this as well. The history is very significant. The history of the drug war is significant, and something that people ask me all the time is, all the time I'm asked, well, what are we going to do to stop people from using drugs? Well, we never have stopped people from using drugs. Drugs are not a new thing. And in fact, when we look back into human history, 7,000 to 6,600 BC, we found some drug residue, alcohol residue found in ancient Chinese village. Hallucinogens were used 8,600 to 5,600 BC. Opium, 4,000 BC. Coca, 6,000 BC. So what we do know is, the history of mankind, we have seen substances, and humans by nature like that effect. So people like that effect of dopamine. They like the effect of feeling better. And so, yes, there's things that we can do to reduce harms and to treat folks when they develop a use disorder. But again, drugs are not a new thing. So this is not a problem that, let me go back here. Sorry. Oh, sorry, my screen is messing up. So here we go. I wanted to talk a little bit about also that we actually, in the medical field, we supported substance use. So, we used cocaine. I mean, cocaine does work for toothaches, right? I can remember the first time I ordered cocaine to help with, epistaxis that I was treating. So, cocaine has historically been used. It was an instant cure for toothaches. And, we talk about heroin. Heroin was introduced as a cough syrup for children. So, we also introduced a lot of the substances, the same substances that we're incarcerating people for. We actually were providing this for medical care. And a little brief history on the U.S. Drug laws, and Nick touched on this, that many of the drug laws that were developed were actually developed with clear notions of racism. These were absolutely racist drug laws. So the war on drugs was a war on Black people. I mean, we just have to recognize that and keep that in our minds when we are moving forward with treatment, when we're trying to recognize the disparities that are apparent in our communities, and also recognize that we were trying to incarcerate this. So it's really important. So I do have a question, and you could answer it in your mind, but what was the first law passed in the US to regulate drug use? And I think we already gave this one away a little bit, but just when do you think the first law that was passed in the US to regulate drug use, and why? So it was in 1875, and this was based on racism, actually, with these opium smoking establishments that were kept by the Chinese. So this was specifically targeted towards the Chinese in San Francisco at the time, and there was this idea of developing laws to force the Chinese must go, right? So this was developed in an effort to completely separate and to harm a certain race. And so I just have to recognize that it's really important to think about all of these drug laws, and a lot of this has a roots in how we see substance use, right? So I can tell you my own feeling in the emergency department was, well, this is illegal. Well, this was illegal because somebody made it illegal. There's a lot of how we construct these social norms, and these are just humans who are trying to take power and control over a race. So it's important to recognize that. Again, there's a lot of intersection here with Nick's talk, but this is how we were talking about marijuana. Reefer makes darkies think they're as good as white men. So they're talking about weird orgies, wild parties, unleashed passions, really trying to stoke fear and separation. This is in 1937. So, and then, I won't play this video now. I don't have time, but this is in your slide deck, or you can look this up. But I think this is a really great illustration on the war on drugs from Prohibition to Gold Rush, and it's really well done. It's worth a watch. It's entertaining in that somebody has a lot of skills at telling a story. So I encourage you to take a look. It's only 3.5 or a little under 4 minutes, and available on YouTube. All right, and then more recently, and Nick, I know you touched on this, is that there was a very this is clear language, that there was a very pointed approach to this is John Erickman, Assistant to President Nixon for Domestic Affairs, and this was really making it illegal either against the war or Black, but they got the public to associate hippies with marijuana, Blacks with heroin, and then criminalize both very, very heavily in order to disrupt the communities. And this was effective, and this was very targeted. So I just have to call your attention to this very racist history in drug laws. So what have we done with the drug war? Well, we have criminalized drugs, and we've put an enormous amount of people in prisons and jails for drug offenses. So this is to call your attention just to the evidence. So this is, from 1980, and I was alive in 1980, just so y'all know, through 2018, you can see how many individuals were in prisons and jails for drug offenses. So we went from almost 41,000 in 1980 to more than 443,000 individuals in 2018. So this is an enormous increase. So, certainly what the Nixon administration proposed and started this all became a huge reality. So we have this enormous, incarcerated population, people in prisons and jails. And again, for drug offenses. And who is in jail for drug offenses? So again, Nick recognized that illicit drug use is actually the same between our white population, our black population. But here you can look at drug-related arrests per 100,000 residents of each race. And there's this enormous discrepancy here. This is from Vox. So this is really important to recognize that we are following through with these norms that were established by an administration who was targeting Black people. So, and then, you can say, well, drugs have caused more violent crime. You could say drugs have caused more property crime. And we actually saw violent crime and property crime decrease. This is through 2012, while this incarceration rate was skyrocketing. So no, there was not this correlation between increased violent crime and property crime. So again, incarceration rose even after crime fell, and this was all relative to 1978. And so then you can look at the likelihood of being imprisoned based on your gender and your race. And of course, I call your attention to Black men in particular, but you can look at women as well and look at Black women and the much higher likelihood of being imprisoned just by your race and by your gender, and Latino men as well. So it's really important to call out these enormous discrepancies and recognizing that drug use is the same, right? So this is, it's appalling, but it's something that we need to treat. We need to treat medically, and we need to recognize and try to break up the system. And just as a world marker, we have the highest incarceration rate in the world. So you can look at the population, world prison populations, and incarceration rates. And in the United States in particular, we have this enormous incarceration rate. Now, what do we do when people go to prison? Do I talk to people and I say, hey, how did you change your life? And I do have people who tell me, well, I went to prison. Now, I wish we had a better way of doing this. And luckily in California, we have finally adopted some protocols to treat folks while they're in prison with medications. But when we don't, was the history, we actually at one point in California had this huge amount of opioid overdoses in prison. As it turns out, people are able to get drugs in prison. And what's even worse, though, is when folks get out of prison, we have this 100 times increased risk of overdose than the general population. There's a 60% decrease in overdose mortality when medication's actually provided. So medication works in correctional facilities and keeps folks safe. And I say this all the time. A lot of folks we can see how often we imprison people in the United States. These should not be death sentences, right? We should not be giving death sentences for petty crimes, for drug possession. And unfortunately, that's what it turns into. So when we look at assessing the community impact of incarceration on overdose, I bring up this slide. There's this, there's the fatal overdoses after, this is weeks after release, fatal overdoses in this cohort by week following their release date. And you know what it looks like? This looks like when non-fatal overdoses come to the emergency department and are not treated with medications. We have this really high, and it's actually higher than that, really high rate of overdose deaths, so fatal overdoses after incarceration. And we have to recognize this and know that this is an extremely vulnerable time, and there's a very high rate of death afterwards when folks are not treated. So again, just to drive this home, this is actually the Cox regret. This is the survival curve following. I studied this in biostatistics. So following release from jail, and this is when folks go to jail for a syringe-related charge. So these are folks going to jail for a drug-related charge, syringe-related charge, and this is their decreased survival once they are released. So this significant decrease rate of survival. So what we do know is that this drug war has had many health consequences, and the racism involved in the drug war has had huge health consequences. So concentrated policing, we've had a lot of individuals who are arrested and incarcerated based on their substance use. And again, we have established that there is evidence-based medical treatment for this, yet we incarcerate folks without treatment. What does this cause? It causes a lot of trauma, stress, financial instability, and then we predispose folks to problematic substance use. I had a gentleman that I was treating fairly recently after he was released from jail. I have had struggles with my own jail treating. We've made some big moves, and we can get a lot of people treated in jail now, but we still find folks who were not provided treatment in jail. We have begged our jail system to drop them off in our emergency department after incarceration so that we can provide them treatment, so we can decrease mortality. And this has actually been effective, but I do have a person who I talked to recently who had actually discontinued his opioid use, was taking buprenorphine on the street, but when he got to jail, they would not provide it because he was taking it from the street. So he was taken off of buprenorphine. And you know what he found really accessible in jail? He found fentanyl. Very easy for him to use fentanyl in jail. So he used fentanyl in jail, and then he at one point before release got off of fentanyl, was dropped off in my emergency department, and I was able to start him on buprenorphine again. So his highest risk time was when he was in jail, his highest risk time of overdose. And he was in this concentrated area where he had access to fentanyl. So we have to recognize that there is still substance use in jail, in prison. So in the broader context, again, we see these epidemic rates of fatal overdose, and we cannot ignore our justice-involved population. So as it turns out, buprenorphine works for those who are justice involved. And I have worked with jails and prisons, and I understand that there is a difference, meaning there's this fear that people are, because they're in jail, I might as well just be on buprenorphine. There's this fear of that people will fake an opioid use disorder to get buprenorphine. I would argue it keeps folks safe because, again, the drugs are readily available in a lot of our jails. But treating with buprenorphine does work for our justice involved. And if you're talking to folks who are signing checks and providing money, the recidivism and mortality after in-jail buprenorphine is significantly improved. And when we look at this, they did a natural experiment across two similar rural jails in Massachusetts, and amongst those who were justice involved with opioid use disorder, when buprenorphine was offered in jail simultaneously, it reduced their risk of recidivism. So again, when they compared the two, there was a 29% reduction in risk of recidivism, and when they adjusted, it was actually like 34%. And I have to give a shout out to there was actually a study through Wayne State, and I know Sarah just mentioned this in the chat, and I'll mention that. So again, bup works better when it's initiated prior to release. What else does this remind you of? So Gail D'Onofrio did the study that when we give buprenorphine in emergency departments, we double a person's likelihood of being in treatment, in a month. Well, as it turns out, when we initiate buprenorphine prior to release, so a better system than when they were dropping folks off when they were being released in my emergency department, then we saw a significant improvement in outcomes. So, and a significant improvement in retention and community treatment post-release. My folks, so in prisons in California, we're actually giving buprenorphine now. And when I work in a clinic, and when I receive somebody from that clinic after they were released, then these are my most stable patients. They're doing really well. They're trying to rebuild their lives. I just had one gentleman last week who actually was told to get on bupe by his probation officer, and I'd love to give that probation officer a really big hug, because he said, "Hey, I really think you after release, he returned to use after release. He was at really high risk. His probation officer knew that there was something called buprenorphine. He went to our emergency department. We got him started, and I got to see him. He's like 2 or 3 years out. He's got 3 kids. He's got a job, a really great job, a well-paying job. He just bought his first house. He's got this great family life." And we were talking, he was saying, when can I decrease this? And I said, well, you're doing really well right now. But I just have to say, it works. These folks, a lot of these folks are trying to rebuild their lives, and it's like giving the right medication to keep them safe, and they stay in treatment. So we do have, and I'm sure that Sarah put this already into the chat, but what can I do to improve care for patients in custody? So I can tell you, my emergency department does a lot of medical screenings for folks who are going to be incarcerated. So, any of our juveniles who are actually found to have been using drugs, we have to do a we have to do a medical clearance for, and then anybody who's involved in any altercation. So we are a point of contact in our emergency department for our justice involved population. We have to recognize that. And if there's an overdose, if there's substance use, any complications, they come to our emergency department. So because there's not really other care for our folks who are justice involved. So we are a point of medical care for our justice involved population. So what can we do? So really important, number one, just make a clear OUD diagnosis. So this is appropriate. Make sure that you make this clear diagnosis of opioid use disorder. Call it to light. It's really important so that folks get evidence-based treatment and provide treatment. Even if it's for one day, if somebody is in withdrawal, and I see folks who went to prison or went to, actually in my county, went to the county jail, and they are now in withdrawal from opioids, and they bring folks into my emergency department, sweaty, dilated pupils, clear withdrawal, and you say, well, they're not going to continue it in jail. Still provide treatment. They can have a good experience with a medication that stabilizes them. The jail will see that they got better. The person will see that they got better on that medication. So please, even if the jail is not going to continue it, give them treatment. I tend to give them a higher dose. I tend to give them 32 milligrams or more so it lasts longer. So they have a little bit more time. And I always also advocate for my patients to continue buprenorphine. I make it uncomfortable, meaning for the jail to not do it. I will call the jail nurse and say, please continue buprenorphine. I am providing a prescription. My jail will say, well, we don't have anybody who's X-waivered. Then I'll say, well, then go pick up the prescription, And what I do is I have also considered injectable buprenorphine. In fact, we have done this through my emergency department, arranged for injectable buprenorphine so that somebody who is going to be in jail for more than a month and they weren't willing to give buprenorphine in the jail, we gave them a 1 month injectable, it lasts for a month, and we were able to make arrangements for them. Provide really clear instructions to the patient. Let them know that there's this medication available. I always send a prescription to the pharmacy because sometimes my folks are released. I never have any idea because they're going to their arraignment or they're going to their court date. So I send a prescription to the pharmacy so that a prescription is available to them upon release. And then so these are the things you can do today from your emergency department. That is really, really important. And then of course, identify these barriers and support change. My Opioid Coalition did a meeting at the jail to shed light on this, that we have treatment. We have ways to make a difference in this jail. And we really have pushed them to get more X-waivered clinicians involved in treatment in jail. All right, so I'm going to move on. Incarceration is a big one. Please work with your local jails. Make sure your prisons are offering buprenorphine. I'm going to get into now something that is a big passion of mine. I live and work in a rural community. I have a community that's 45 minutes from me, but it's only 10 miles away. There's a huge fire there now. If you look up the mosquito fire, it's this enormous fire right now that has displaced a lot of individuals. And there's a lot of people in my community who are suffering, who are living in shelters. And this has become actually seasonal. We have seasonal fires. We have a lot of disparities based on geography. We have a lot of suffering based on smoke inhalation and people having to run from their homes to avoid these fires. So I just have to give a plug to what's going on in my own community. But I work with rural communities, not only in California, but across the nation. And there's a lot of these disparities in treatment that I'd like to call out. And I'd also like to call out that this type of program of initiating buprenorphine from the emergency department will create enormous change in communities and save lives. So these are just some rural barriers to treatment. Access. We all know access for a lot of things is decreased in rural communities. So 29%, almost 30% of folks live in a county with no buprenorphine. So these are in rural counties across the U.S., whereas in urban communities, there's only 2.2% of folks who live in a county with no buprenorphine. So there's this enormous disparity with rural access to buprenorphine. And what we do know, there's also these great distances to care. I already said there's a community 10 miles away from me, Georgetown, and Quintet's like an hour away. They're not very, as a crow flies, it's like 10 miles away, but these, dangerous mountain roads, great distances to care, no bus goes there. I literally have communities in my county where police won't even go because it's too outlaw. So this is in California, I'm telling you. And a lot of these rural counties, in fact, 88.6% don't have any opioid treatment facilities, so there's no methadone access at all. In my community, there is one methadone clinic that's a satellite clinic that just opened 2 or 3 years ago, and you once a week still have to go to the big city, which is an hour away each direction. So you literally have to take at least a half day to go to this clinic that's a huge distance away, and we don't have natural transportation there. So a lot of people are relying on friends and family because there's no public transportation. I have one bus. The bus is almost always late. It doesn't always run, and so it's very unpredictable. So most of the folks in my county do not have any public transportation. We don't even have reliable Uber. So you cannot usually find an Uber in my town. So, and then the treatment centers in a lot of rural communities are much less likely to offer medications, unfortunately. And I just have to remind you that only 10% of Americans with a substance use disorder receive any type of substance use disorder treatment at all, and only a small fraction receive FDA-approved medication, right? So we're already dealing with a landscape where very few have access to treatment, very few receive the actual evidence-based treatment, and now we move that into rural counties and rural towns. So there's what I'm going to review here is there's a high need versus low to no buprenorphine capacity. So there's 41% of urban counties that still have high need, so high opioid overdose rates and low buprenorphine capacity, low to no buprenorphine capacity. But this is significantly increased in rural counties. So I want to look specifically, here's the nation, and what you'll see is those dark blue areas are high need, low capacity counties. So this is important to look at. You can see like these counties, you can see states where there's some pretty enormous counties actually across the US who have high need and low capacity. The light blue are high need, but they're not low capacity. So meaning they're high need communities, but they've built some capacity. And so these, and then of course, all over these are urban or low need rural counties as well. I want to point out Michigan, and this is an imperfect slide, but I wanted to illustrate the dark blue counties here are these high need and low to no buprenorphine. And then the map on the right, those are counties with hospitals and emergency departments. So I need to point out here, they're different colors because this was actually a COVID map. This was being utilized to show which hospitals had intensive care units. So there's different colors based on which hospitals in these counties have intensive care units or not. But what I want to note is the dark blue counties are the ones with very high need and low to no buprenorphine. Now, I want you to compare those counties, look over to see if there's an emergency department or hospital in those counties. And you can see by and large, there are emergency departments and hospitals in these counties with high need. So that's why it's incredibly important to initiate programs in these counties. And this is just, I put this all over. This is high need, low capacity counts. So there's actually a lot of these counties where you look at high need, low capacity. You might recognize some of these counties here where there's high need and there's zero patient capacity rate. 4 out of the 6 of these have zero capacity, and there's some that have some capacity but need more. So there's room to grow, and again, there's hospitals in these areas. And emergency departments are uniquely positioned to provide treatment access and improve the entire delivery system. We know that emergency departments are the safety net. I apologize that the words don't seem to have shown up here, but they're the ultimate safety net. Emergency departments, again, are frequently on. If there's that one bus, the emergency departments frequently are on the bus route. Mine is. I can tell you my community clinic, which actually has buprenorphine available, is not on the bus route. A bridge clinic across the street from my hospital does provide it. So it just makes it, and there's a significant increased rate of people utilizing that bridge clinic because it's on the bus route. It's where people can get. Emergency departments are very versatile. Again, you can give buprenorphine in your emergency department today without an X waiver. But when you get an X waiver, you create this enormous capacity for folks. You can hold them over until they can get to the clinic. And then emergency departments have the ability to connect with community. And that's what we do, is we bring in all these outside resources to the human being in front of us in our emergency department. And I have to make a statement as well that, like, I can tell you in my emergency department, department, when we started giving buprenorphine, we only had like 1 or 2 X-waivered providers in this clinic who were giving bupe. But when we started doing this, we made it normal in my rural county to give buprenorphine. And now it's the expectation in every system in my county. So my tribal partners, they're at their clinic, they are giving buprenorphine. They have X-waivers. At the FQHC, they have 2 clinics now that are going to give buprenorphine. My own hospital system developed a bridge clinic to give buprenorphine. In that town of Georgetown that's facing that fire right now, we have an X-waivered primary care nurse practitioner up there who is giving buprenorphine. So we have created capacity because our emergency department has made a big change here. So again, very important. This is just to point out, we did publish in Annals of Emergency Medicine. The point I want to make here is that we were able to rapidly implement programs just as fast in rural emergency departments and hospitals as we were in urban. So there's a myth out there that this is too hard in a rural area. This is easy to do in rural environments. And I just traveled to the most rural hospital in California. There's two rooms in the emergency department. In the hospital, they have emergency department, they have a clinic, they have a behavioral health clinic, they have a CT scanner, which I was really impressed by. They have lab, x-ray, and they even have a skilled nursing facility. And I took a picture on the left. It's in a house. It's in a single-story house. This is in Garberville, in like the northern kind of coast of California. It took me, I live in Northern California. It took me five and a half hours to get there. So very, very remote. They even have a pharmacy. There was no pharmacies in town when I first started working with them a year ago, and the hospital was able to provide a pharmacy so that people could pick up their buprenorphine. They give buprenorphine. They have a navigator. This is Scott Sullivan. He is making huge changes there, and they've even done a lot of work with the people who are experiencing homelessness there. And so they were able to work with their community partners and get housing for folks. So key takeaways here, just rural emergency department medications for addiction treatment can be just as quickly implemented, like I said, as in urban environments. Rural emergency departments make it safe for the community to engage in evidence-based treatment. I would consider injectable buprenorphine due to transportation issues. So we have 130 people who are receiving injectable buprenorphine because they live in Georgetown or they live, in these really rural areas, and it's hard for them to get to the emergency or to get to their clinic. Connect with the community resources. In rural communities, they tend to be very far apart and difficult to access. Connect with them through your emergency department. And a bridge clinic model with navigators who can help folks navigate these rural environments can be very, very impactful. All right. Thank you. I don't know if there's any questions, but thank you for your attention. And happy if you email me or call me or anything like that, I'll put my phone number and email in the chat. Would love to talk rural populations as well as justice involved. All right.
Sorry, when I took over control of the meeting, it was like, no, you can't also unmute yourself at the same time. We are just going to forever immortalize my ineptitude when it comes to computers. That's my goal today. So I'm, again, Kara Poland, and I'm going to be starting out by talking about disparities in pregnancy, and then we'll move on to speak a little bit about adolescents or young adults. So I started out with a little case. So we have a person who presents who's been on MOUD with another prescriber. She's been pregnant before and asks about transitioning to buprenorphine mono product, as that's what's happened in her previous pregnancies. So we mostly prescribe buprenorphine in a dual product that has buprenorphine as well as naloxone in it. And historically, there was concern for a hypothetical risk of withdrawal in that neonate if we gave the person the combination product with the naloxone in it. We've since found out that it's actually not really, doesn't get to the baby. They've done some limited cord blood studies that show there's not enough naloxone getting to the fetus to potentially cause any kind of distress or withdrawal. So The key point on this is just to understand that you can continue people on the buprenorphine mono product, on the buprenorphine dual product, and not need to be concerned about negative impacts or effects on that pregnancy. A lot of people just feel more comfortable sticking with what they've been on. I think a lot of us feel the same way about either medications or, I don't know, like if somebody tries to give you a different body wash and it doesn't smell right, it doesn't feel right. So it's sort of like that. It just doesn't feel right to patients often to change that. So sometimes it's also like a bit of a comfort thing for individual patients. So I'm sure people read the case. It wasn't too complicated. So that was my key point on that case. So about 5 to 10% of pregnancies are exposed to opioids, with about 6% of pregnancies having an opioid use disorder. We're seeing some of those numbers start to trickle down in terms of that general exposure to opioids, because we've seen our general prescribing of opioids has reduced in the last 5 or 10 years. It's really important to know that 8 out of 10 people who detox off of opioids while pregnant return to use within 1 month. So a lot of people will think that, well, I should recommend that this person stop their MOUD or stop their treatment because of neonatal abstinence syndrome, when really if we do that, 80% of people will return to either illicit opioid use or back on medication. So what I tell my patients is that I don't have a magic wand to tell if you're in that 20% or that 80%. So if you want to taper, I want to walk that journey with you during your pregnancy. And if at any point it's not going the way you hope it to, we can reassess whether or not we're doing the right thing for you in your pregnancy. But the most important thing is a healthy pregnant person leads to a healthy baby. And we also know that neonatal abstinence syndrome is a time-limited thing. It does not follow that child for years and years and years. As I sort of mentioned already, this is a little bit older data, but as we see maternal use of opioids increase, we see that risk of neonatal abstinence syndrome or neonatal opioid withdrawal syndrome also increase in parallel. Again, this is back in 2014 data, and since then we have seen increases in the rates of opioid use disorder during pregnancy. So this may be happening more frequently than it shows on this slide, but about every 15 minutes, maybe a little bit more frequently, a baby is born with opioid withdrawal. This is some Michigan specific data looking at neonatal abstinence syndrome specifically in Michigan. You can see higher rates in the Upper Peninsula as well, and in kind of the thumb region. And so hopefully we will be able to continue to address that through many of the interventions that we have, reducing the risk. But the most important one is making sure that pregnant people have access to life-saving FDA-approved medications to treat an opioid use disorder. So here are some of the complications. Untreated heroin use is associated with some negative outcomes, including but not limited to fetal death. And so if we have people that have untreated heroin use, we want to really encourage them to get into treatment. We don't want to attack them with treatment. We want to offer them treatment and support them. I always tell people, I've had patients who have used heroin throughout their pregnancies, but you know what? They're coming in and they're seeing me, and they're coming in and they're getting prenatal care, and they're coming in and we're providing that anticipatory guidance. And I've had many of those patients that used throughout most of their pregnancy, if not their entire pregnancy, then be ready to go into treatment after they deliver and see that baby. And so sometimes people just have different times that they have that readiness to change. And as long as they're engaging with us, we want to keep them coming back and making sure that we continue to offer. So if in the emergency department, you have somebody who keeps coming in and they keep, and it feels really, cyclical, remember that happens with all chronic illnesses. And just like we wouldn't not offer them longitudinal connection to an endocrinologist for their diabetes care, we want to make sure we offer them longitudinal connection for their addiction care. And so we just want to make sure we're continuing to provide that support. So there was a meta-analysis that was recently released. Well, I guess it's been like a year and some change ago, but as I get older, a year ago seems very recent past. So we know that prenatal opioid exposure is a fast-growing health problem, and there is evidence that prenatal exposure can lead to long-term neurocognitive and motor developmental delays into adolescence. The concern with that meta-analysis is it did not separate medication to treat addiction from other opioids, including those illicitly taken. And one of the big reasons that medication for a substance use disorder sort of supports the brain structures and prevents that up and down, that very likely may be the cause. So I tell my patients, if they come in saying, what are the long-term effects, that really the jury is out. We do not know if this article predicts that medication for a substance use disorder actually causes long-term effects. But we do know that not treating it causes long-term effects and has negative outcomes on the immediate pregnancy as well. Treatment is effective, so we want to make sure we engage people, and that often starts in the emergency room. People are often feeling very vulnerable coming into the healthcare system. Well, it's our day-to-day life, it's not their day-to-day life, so it can be very overwhelming, but those can also be, as we like to call them, reachable moments where we can say to a person, are you ready? Let's get you engaged. And if we can do that in the emergency room and have quick follow-up on the outpatient side, then they get that immediate feeling better. We don't get to do that with diabetes, right? Like if you give somebody a dose of insulin, they aren't like super thankful that you just gave them insulin or treated their hypoglycemia. It's more like an asthma exacerbation. They feel better while they're still in the emergency room. And it's kind of nice to have those moments, because it's a moment where somebody might be ready to hear the conversation and get engaged. So methadone is not a treatment option available in many areas of Michigan, although we do have a new methadone clinic, and the first of its kind, just across the border in St. Ignace for Michigan's Upper Peninsula. Otherwise, there is not another methadone clinic across the Upper Peninsula. We also have very few in the northern half of Michigan. So there are many places where methadone just isn't a treatment option. Buprenorphine, as we know, can be prescribed out of the emergency room or out of an office by a provider with that waiver. And we have many people that are in our state not able to access treatment. So medication for addiction treatment is recommended as the best practice for the care of pregnant people with an opioid use disorder. We need to make sure that people have appropriate social support, can get to those appointments, can be available, as well as access to counseling should they choose to engage in counseling. But that's where having your social worker or a recovery coach in the emergency room can be very helpful to help us make those long-term transitions out of care, and also to start building that trust in the healthcare system. We generally, again, treat opioid use disorders with buprenorphine or methadone to prevent withdrawal, reduce cravings, and reduce kind of the ups and downs. So whether that's the euphoria or the withdrawal. It also improves outcomes for the pregnancy beyond that. So it improves nutrition. We have usually increased birth weights and reduced exposure to infections that are complications of IV drug use. We are going to move on to speak about disparities based on age, or being an adolescent, also known as. So I have. This is actually a case I was consulted on that I based this one out of. The other one was just completely arbitrarily made up because I was like, I really want to hammer home the fact that buprenorphine naloxone combination product is safe in pregnancy, and we don't need to worry about having different formularies or different pathways for medication to treat an opioid use disorder during pregnancy for our emergency departments. So we've got a 15-year-old male who presents with anxiety. The parents are with him. Mother reported to the pediatrician 2 months ago some concern for falling grades, lack of engagement, and changes in friends. all signs of something happening in an adolescent's life, which could be related to substance use. The child appears agitated. The CRAFT screening score is 3. We'll go over the CRAFT in just a minute, but it's adolescent screen for substance use disorders for those of you that are not familiar with it. You identify that he's become a daily marijuana user, though he reports no use in the last 24 hours because he's been unable to obtain marijuana, because adolescents are opportunistic users. So often they use what is available because they don't have the ability to drive to the marijuana dispensary the way that I would if I so chose, because at 15 years old, they're not old enough to access marijuana through a dispensary. Same thing happens with alcohol, same thing happens with other substances. So sometimes we'll also see adolescents where they primarily use one substance, but they also like have a broader polysubstance use picture because the substance that is most rewarding to their brain is not always accessible. So you provide that brief intervention in the emergency department. We know that brief interventions are proven to help in an adolescent that has risky drinking. So not necessarily disordered drinking, not a substance use disorder, but has risky drinking. Having a physician say to that adolescent, hey, yo, not healthy, you should cut back, you should stop drinking, that's not like good for you, actually reduces an adolescent's alcohol use by over 50%. In adults, it reduces it by like a blanket 50%, but in adolescents, we actually have higher impact than in adults. So, because adolescents listen to us, I mean, shockingly, they actually do. Can you tell I'm like starting to get into adolescence with my children? You talk to him and his parents about engaging with the pediatrician regarding the marijuana use, and send your note to the pediatrician expressing concern. I really want to emphasize the fact that brief interventions are really important. And then that communication back to the pediatrician to close that circle between what mom has reported to the pediatrician, as well as what you are seeing in the emergency room. I know they have some updated data, but I didn't have an opportunity to pull it, but this is the Monitoring the Future study. It's actually done out of University of Michigan. So their representative sample, wink, wink, is Michigan adolescents. So we can see that the red are increasing. So we are seeing increase in vaping overall, as particularly nicotine and marijuana, and actually a decrease in vaping of just flavoring, exactly the opposite of what we want to see. But we still have a lot of adolescents that report when you ask them that they thought that they were just vaping flavoring, even though they are self-reporting that they are not just vaping flavoring. So take that with a heavy grain of salt there. So again, we're seeing a lot of increase in marijuana use and a decrease in much of the other substance use, but also an increase specifically in vaping of nicotine. We are seeing a decrease in prescription drug misuse from peak years in adolescents. This is not different than what we are seeing in adults in terms of prescription medications. As we've seen prescribing decrease by 50%, we've seen a use of illicit prescription medications decreasing. However, it has not had the impact that we hoped it would have on the overdose death rates. In fact, as I'm sure we're all aware, since 2019, we've only seen increases in opioid overdoses in the United States. So kind of need to keep pushing the envelope there. And that's why also providing access to MOUD for adolescents is important. So confidentiality laws vary from state to state. However, in Michigan, 12-year-olds have a right without parent or guardian knowledge or consent to seek substance use disorder treatment. What is really important to understand is that if that adolescent comes in and they seek care without their parent and it goes through the insurance carrier, the parent will receive the explanation of benefits, and they will see what medications were prescribed and what the diagnostic codes are based on the health insurance. So that is something to be aware of. We also know that adolescent care in substance use disorder has improved outcomes if we utilize family-based care models. So we we don't encourage people to treat the adolescent without the family involvement based on those particular outcomes. But there are certainly times or indications where maybe you would want to treat the adolescent independently if they're on the road to becoming an emancipated minor, if there are other risk factors in their family that maybe make it more dangerous to disclose than to not disclose. But usually we want to kind of try to engage those people that are within that adolescent's sphere of support, and often that is family members. But we technically, for children older than 12, have the ability to provide substance use disorder without treatment, without parental consent. There's a good document from University of Michigan that kind of describes, it's like a one-pager that kind of describes those consent laws, and it's easily accessible as well. So teens often don't seek treatment on their own. Many times it's like this, like the case that I presented, where the parent is expressing these concerns. That 15-year-old was likely just in marijuana withdrawal, 24 hours without marijuana use, chronically using marijuana could present as anxiety. There's often external pressure coming from school, coming from the criminal legal system, coming from parents or guardians. They often are quite ambivalent about treatment and aren't strongly motivated to engage in treatment, at least initially. So sometimes with adolescents, we want to consider that harm reduction and not abstinence. So at times saying, substance use is terrible for you and everything is going to go to the gutter if you continue to use, doesn't really ring for adolescents. I know if I think about 17-year-old Kara, I really didn't have a concept of like what my life was going to look like in 10 years. And so their brain is still developing, and they really don't have the frontal lobe capacity for those types of executive decisions and executive thoughts. So often they also need multiple treatment episodes in order to sustain longitudinal treatment, which is not different than adults. Those adolescents that seek treatment often have a shorter time period from initiation of substance use to actually engagement in treatment. So they tend to have pretty significant and severe substance use disorders. Their substance-related problems are just different than their adult counterparts because they're adolescents. So we are not often talking to our adults that are in their 40s and 50s about their grades at school. Whereas with an adolescent, we want to support their academic achievement as well. And as I mentioned previously, they tend to use opportunistically, and when they do use, they tend to display binging behaviors as well. So here is the CRAFT screen. This is built into many EMRs, but it is adolescent specific. Again, this is a place where maybe a social worker or a recovery coach in your emergency department may be a great support to provide this screening, because it does kind of, in a busy emergency room, there may not be the opportunity to sit down with the patient and ask these questions. So it might be a time period where we can rely on our colleagues in the emergency room. So let's talk a little bit about pharmacotherapy for opioid use disorder in adolescents. So buprenorphine and naloxone have been shown to prevent disease recurrence, reduce craving, and eliminate withdrawal symptoms in this population. Although it's not FDA approved for those under 18, in Michigan, we are allowed to use it in 16 to 18-year-olds, and it is regularly given off-label for 16 to 18-year-olds across the nation. The American Academy of Pediatrics does have a policy statement advocating for increased access to medication for an opioid use disorder. The problem is that only 1% of pediatricians actually have a waiver to prescribe buprenorphine, so it can often be difficult to find a pediatrician locally or a family medicine provider locally who is willing and competent to treat a person, an adolescent with an opioid use disorder. In the state of Michigan, in terms of methadone, because federally methadone you cannot prescribe to persons under 18. Of course, if somebody is 18 or over and is a later adolescent, we can enroll them in a methadone clinic. Sorry, I said prescribed, and that's like not right. We cannot dispense methadone to a person under 18 through a methadone clinic. But in Michigan, there is a waiver process for the adolescent age group 16 to 18 that a methadone clinic can go through in order to be able to accept an adolescent here in Michigan. And that is regulated at the state level. So these are some of the evidence-based behavioral therapies that work in adolescents. You can see that some of them are very similar to what's done in our adult counterparts, but some are very different and focus again on that family as the unit rather than as the individual adolescent. It's probably beyond the scope of what emergency physicians would or providers would need to do. So I just wanted to bring this awareness because you may have people who return and who are there with and who certainly are there with their parents. And we know that the parents, it may be an opportunity to ask the parents if they are in treatment or have access to psychotherapy to help them support their adolescent as well. So these behavioral interventions essentially work with the adolescent and their family to support a reduced use of substances, because again, a lot of times adolescents aren't ready for an abstinence-based program, and sort of pivot what is rewarding for the adolescent and what kind of things that they are doing to non-substance use related activities and extracurriculars and school and academics to improve some of these skills. There's also a large focus on improving and supporting the parenting skills and helping the unit as a family better address their internal dynamics in a way that is more supportive of that adolescent. I cannot underscore the amount of guilt and fear that parents have when they have a child that has a substance use disorder. So remembering that this isn't anybody's fault and that they're probably blaming themselves as a parent can be really helpful for us to reframe our own selves, because parents of children that of adolescents and young adults that have a substance use disorder certainly face their own stigma, both from our community as healthcare, but also internally. And that is what I have for slides. And I can open it up for any discussion points. Otherwise, I will transition back to Dr. Rademacher, and we will move on to talking about treatment of other substance use disorders in the ED.
Thanks, Kara. I think after our first or second session, we had a request to talk about other things that we can do in the emergency department outside of opiate use disorder. And so considering this is our last session, we want to take a couple minutes to do that. And so I'm largely going to leave this, oops, sorry. I'm going to claim control. There we go. I have it. Okay. So thank you. So alcohol use disorder, I guess, kind of what I do and what I've started to do recently is I did come across a small study that was actually by Andrew Herring, who, clinically, I think assists the California Bridge Project in their protocols as well. But they had a small pilot study, just 59 patients, that showed that in the emergency department, if they were able to give someone IM naltrexone for the treatment of alcohol use disorder, they were more likely to follow up and be engaged in care, I think in a month. And it was only 10% for oral naltrexone. So, 10% isn't zero. I don't know what the control was, but based on this small amount of data, I think the downside is pretty minimal. I've started to give naltrexone orally to patients that express desire to reduce cravings and return to use to alcohol. I also, pretty consistently do benzodiazepine tapers so that they don't go through withdrawal. I think inpatient treatment has been really hard to come by. Of course, if someone's in moderate or severe alcohol withdrawal, admit them. But if they're not in withdrawal and we're going to discharge them to initiate care as an outpatient, then I will assist with a taper. Coming across or trying to like research a research and evidence-based taper has been a little bit challenging in the time I had last night. It's kind of all over the place. I guess I've traditionally done like 5 days. I think after my literature review from last night, I'm probably going to do more like 10 in the future. So that's kind of how I do this, but I'm open to hearing how Kara and Ariana approach this and would recommend and how they would treat other disorders as well.
Yeah, Nick, I was going to say, I actually, we've changed our standard in my emergency department. We kind of use like all of the work we did for opioid use disorder as that like open door to like, yeah, okay, so we really examined what we're doing for other substance use disorders. And for alcohol use disorder, our standard is to give, even if somebody says they're not ready to quit, we'll offer naltrexone to decrease craving. So I'll say, well, do you want to drink less? And if they say, yeah, this isn't really going well, because frequently they're in my department because things aren't going well. And so I will give naltrexone to them pretty routinely. And then I'll also offer gabapentin. In fact, somebody who wasn't ready to completely quit but wanted to reduce was going through some withdrawal, but wasn't really going to stop entirely, so I didn't feel comfortable giving benzos. So I gave gabapentin and naltrexone, and I do that very frequently. Another pearl, we actually ran out of in IV Ativan recently. But even before that, we were giving single-dose phenobarbital from the ED for folks who were actually going home. There's an MCRIT article out there about phenobarbital in terms of use in alcohol withdrawal that I invite you to take a look at. I don't have the link right now, but there's a good MCRIT article out there that is great for looking at some advances in treatment of alcohol use disorder, alcohol withdrawal. But thanks. And I wish I'm trying to get injectable naltrexone on formulary based on the study that you talked about from Highland and talking to their head researcher in terms of this. It was really effective, especially for folks who just come in very frequently with complications related to their alcohol use. This was a way to, they found that they were able to reduce their morbidities, reduce how often folks were being seen. These are some folks who are being seen daily who then they'd see in a few weeks or a month. So can reduce craving and make a big difference, especially in some of our most vulnerable folks. So.
And you said
Sarah,
you do
what about you?
treatment for meth use too?
Oh yeah, I love talking about methamphetamine use. So I was just part of a center of excellence. I know sometimes I say things and I don't realize where I am, and I'm like, oh yeah, I love talking meth. So sorry about my enthusiasm, but we've been we had a project at California Bridge to take on meth because this has been, a lot of folks I talk to across the country say, well, I don't know about opioids, but I see meth, complications all the time. And I can tell you the opioid related issues are there. Folks just may not be comfortable talking to you about it. Certainly, we see a lot of complications related to methamphetamine use. So if I could give just a little, just where we're landing with methamphetamine related issues. We are developing currently a tool at California Bridge. So stay tuned. We're trying to make it a little bit better with some pictures and to create a better understanding. So we will have a resource available soon to address methamphetamine from your department. But what really, like, when we talk about methamphetamine, people love it because it makes it feel really good, right? First use, we typically don't see issues. People just feel really great. They have a great time. They're more alert. A lot of folks I actually talk to who are using methamphetamine who are on the street say they have to use it to stay awake to keep their stuff. Otherwise somebody will steal their stuff. They have to be alert to protect their loved one. So there's some folks out there who are using methamphetamine for some pretty legitimate reasons. So I just have to put that out there. What happens though is this decreased sleep is what really triggers a lot of badness. So folks weren't sleeping several nights in a row. And that's when we really start to see psychosis, agitation. We also, over prolonged use, we see cardiovascular disease, congestive heart failure. We see, risk of stroke. All those things actually happen over usually other things that are coming into play to complicate the methamphetamine use. So when I have somebody who's coming in, and this is very frequent, almost daily, who's agitated from their methamphetamine use, then we want to allow them to sleep. So how do we get there? So frequently we have lots of tools in the tool belt in the emergency department, of course, to so use your we use olanzapine a lot. We'll give 10 milligrams of olanzapine for folks who are experiencing some psychosis or agitation. I will frequently try to give some hydroxyzine if it's indicated, so that they can sleep, and really I try to get them into a quiet, calm, dark room so they can get some sleep, because everything changes when they are able to get some sleep. Everything changes. So allowing sleep as a treatment. And I have some folks who still come in and they're not agitated or psychotic. They just kind of feel like they're still crawling out of their skin because they haven't slept. And so there are a couple of routes you can go with treating craving for meth. And mirtazapine, 30 milligrams once in the ED, is one that we've utilized because there's a little bit of evidence behind it. None of the evidence is as strong as buprenorphine, but there's some evidence behind mirtazapine. So we'll give 30 milligrams once in the ED, and I've paired that also with hydroxyzine to allow sleep. And I just had somebody who was entering treatment. They were at a residential treatment facility and just kind of couldn't get there, and I gave them mirtazapine and hydroxyzine and let them sleep. And when they awoke, they said, I feel so much better. And then I kept them at mirtazapine actually daily for 7 days, and then had them follow up. So we, if you go to highlandbridge.org, yeah, there you go. There's the AUD treatment. If you go to highlandbridge.org, they actually have a lot of these methamphetamine treatment pathways that are available there. Bless you. And then there's one more route that you can go that there's some evidence behind, which is the combination of bupropion and naltrexone. I have a lot of fentanyl in my community, so it's really hard to get folks on naltrexone who've been using meth because there's so much just co-use. So I haven't been able to get there from my emergency department, but there's different drug markets in different places, and some of my partners at other facilities have been able to successfully use, there's that guide. Thank you. And then highlandbridge.org, thank you, have been able to successfully use bupropion with naltrexone. Some of the tox fellows are really uncomfortable with bupropion because it's pretty easy and really damaging to overdose on it. So I just have to put a word out there that caution your patients, because those bupropion overdoses are very difficult to manage. But that is a pathway that has proved successful. So what I can tell you from the Centers of Excellence project at California Bridge, the hospitals that were using this mirtazapine protocol, we had a 30% follow-up rate. That's pretty good, considering before we had a 0% follow-up rate for methamphetamine. So at my clinic, we're doing contingency management, we're doing groups, we're doing CBT. So we're doing a lot of different things in clinics. So we still refer folks who are looking for change. I had one last night who I just referred to our Bridge clinic who was struggling with meth, and she was pregnant. She was really interested in help. So we referred her to our Bridge clinic as well. So can you do something about meth? Yes. Is it as robust as buprenorphine? No. But again, 30% follow-up, that's not bad. So I encourage you to take a look at those Highland resources, and soon we'll have one available specifically from California Bridge. Thanks.
Awesome. That's helpful. Thank you. Okay. So we'll send out the PDF and the resources in the chat.
Yeah, and Nick, I was going to say one more. You were, we were talking about benzos. Benzos come up a lot. Kara, I don't know if you have. I'm always looking for the magic with benzos because those Xanny bars are really prolific in my community. So, Kara, what are you doing for benzos?
I actually, because clinically I work with pregnant people, so I often actually take on the illicit use and start prescribing it, which causes everyone to like feel like their stomach is dropping. But in pregnancy, I'd rather know what my patient is taking. And then I usually use the Ashton protocol or something similar to do a bit of a longer term taper. The risks that we used to think about in pregnancy have largely been debunked when it comes to benzodiazepines. Everyone still likes to talk about them though. It's real fun, but they've mostly been disproven. So I often actually take over the illicit prescribing and then taper, you know, I will intermittently, like across time, not at every visit, but because usually these tapers are 3 to 6 months long, check levels because they should generally be decreasing, but it's so reliant on when the patient actually took their last dose that it's not really helpful if you check it too frequently. And you know, kind of maintain that close follow-up with them. You know, they're not somebody who I'm going to be prescribing a month worth of medication for. It's a little bit of contingency management in my head. Come in, let's get you, we know we want you to get down on this. We also find that if people actually if you can get somebody to reduce their benzodiazepine use by 50%, that is when they start actually feeling better. And so often I am talking to patients, I'm reminding patients of that. Like, I know this isn't the best, but right now, but if we can quickly get you to 50%, which has decreased risk, then you'll start to feel better and we'll get you, we'll get you back up to speed.
Yeah, no, thank you for that. Because one thing is, all the complications I see with bup are usually with benzos. I said all are usually, but they're associated with benzos, and it's either it can be also from cutting them off, right? They can seize. So the seizures I've seen, somebody will say, "Oh, you just started bup," and they seize, and it's like when you dig into it, it's always the benzos. So, and then when people are sedate, or there's some polypharmacy involved, it's the benzos. So that it's always tricky, always really tricky.
It's the benzos, and the other one that's similar that I love to hate is gabapentin. We see a lot of complications from long-term use of gabapentin, especially in combination with some of these other substances, because like benzodiazepines, we don't see a lot of primary gabapentin or gabapentin alone. It's been very difficult for us to get a lot of information on the gabapentin itself withdrawal syndrome or the gabapentin itself consequences. So I'm on a constant crusade to be like, be careful with gabapentin. It does have some pretty decent evidence in the first 90 days of addiction treatment, which is probably when you all are going to be seeing somebody. But just remember, for somebody who's been on it for 5 years, they may not be driving benefit and may be driving more harm.
Yeah, that's a good point. Thank you.
Awesome. Yeah. Well, thank you. I think that closes we've had a summer long lecture series, and this is the last one. So Ariana, thank you so much for assisting with all these. Kara, thank you for joining us for this one. And Sarah Wendels, thank you so much for helping with all the resources in the chat. And of course, we need to acknowledge that behind the scenes, the Community Foundation for Southeast Michigan has been a wonderful support for all of us. They put everything together. So Marissa Natsky's always in the chat and in the lobby monitoring things for us. We have Emily Angel here today, and I don't think Lisa Jones is with us. And then of course Sarah Weddapole is leading everything. And then of course our partnership with MHA has been really helpful. And so thank you very much, Naomi, for assisting us with these presentations over the past couple of months. All right, everyone have a great weekend.
All
Thanks,
right,
everyone.
Thank you so much, Nick. Thank you.